Welcome to the Beauty of Breathing podcast, where we explore the wonders of optimal breathing. I'm Renata Nami, a dedicated mom, entrepreneur, and myofunctional therapist committed to embodying the principles I advocate. Having recently undergone a tongue-tie release and palatal expansion, I'm thrilled to guide you through the transformative journey of embracing the beauty of breathing, effortlessly and through your nose. Let us know how much you enjoy the show by leaving us a review. We are live. Welcome everybody to the Beauty of Breathing podcast recording. Today I have a very special guest with us, Dr. Pia Gandhi. She's a great friend of mine and an incredible practitioner. I am going to let her introduce herself to you guys, let you guys know where she practices, how to get in touch with her, and all of that. Go ahead.
Hi there. I am Dr. Pia Gandhi. I'm a board-certified pediatric dentist that specializes in pediatric airway and oral dysfunction. I practice in Houston, Texas. I have two practices, Westview Pediatric Dentistry and Tanglewood Pediatric Dentistry. And those are our Instagram handles as well. So you can look us up there. And we start treating for oral dysfunction at birth. And even though I'm pediatric, I do treat some adults as well, but my focus is mainly children.
Awesome. So today's topic, we're going to talk about breathing and bedwetting. How are those two connected? We got so many questions this last week on Instagram from parents going, but hold on, my child is bedwetting and pediatricians are saying that they're fine, or this is just going to, it's something they're going to grow out of. How is bedwetting related to how a child is breathing during sleep?
Sure. So, there's two types of bedwetting. One is primary bedwetting, which is normal for a young child that during the potty training process and when they're little, just never was able to hold their urine through the night. But that should tend to go away by 4 or 5 years old. Then there's secondary bedwetting, which is due to an underlying medical condition or something else that's disrupting our body's ability to really hold our urine during sleep. And when sleep is disrupted, we really don't go through normal sleep cycles. And so the body doesn't regulate hormones correctly because we're constantly in this fight or flight stage of sleep, usually the beginning stages of sleep where our body is still really active, especially if we're having trouble oxygenating because of sleep apnea. Our body is fighting to just give as much to our brain to keep breathing that it is not allowing the proper regulation of the hormones that allow our bodies to absorb more liquid while we're sleeping so that our bladder doesn't get full. And so we see this with obstructive sleep apnea when children are struggling to get into the restful cycle of sleep. And so this can continue, into the teen years sometimes. And what we see sometimes is when they're little and they're 4 or 5, they're actually able to not bedwet. And then as their body continues to grow, if the airway is not growing with them, they can actually start to bedwet again because, again, that cycle of not being able to get into a deep level of sleep where the hormones are regulated correctly.
That is perfect. So that goes back to, okay, but hold on. I have a child and they are showing certain symptoms that every other healthcare professional tells me that they are normal symptoms. And I just heard Renata say on Instagram that bedwetting is related to maybe not breathing very well at night. What is the problem? What are some things that I should be looking for on a child who may be mouth breathing? A lot of times we don't even notice our child mouth breathes, but there are certain things that we can look at that we're like, and I'll give you guys one. For example, if you're constantly telling your children, close your mouth whenever they're chewing, a lot of times it's because they cannot breathe and chew at the same time. They could have enlarged tonsils, enlarged adenoids. And it's not because they don't want to. They know it's wrong. Kids are pleasers. They want to please everybody. So they're not doing because they're bad. They're doing because maybe they cannot do it any otherwise. So besides chewing with the mouth open, what are some other signs of mouth breathing in children?
Yeah, a really easy one to pick up on is chapped lips. So if your child constantly has chapped lips and then they start licking their lips because they think that's going to help and it makes it worse, that is a sign that we are mouth breathing because it's just drying everything out. So that's one. When they're sleeping. If you wake them up in the morning and their sheets are everywhere and their hair is a mess and they're sideways on the bed, that is a sign that we are not sleeping well. And a lot of it will start with mouth breathing, because when we start to mouth breathe, we don't oxygenate our body as well. It also doesn't allow our jaw to grow correctly when our mouth is open, because our tongue is not elevated and pushing on the upper jaw bones to spread them out. So movement during sleeping is a big one. Kids that drool when they sleep. So even when they're napping, if they're napping on you or whatever, and then they end up having a whole puddle of drool on you, well, that's because their mouth is open the whole time. Kids that just will fall asleep on a dime anywhere inappropriately. And I think, parents and the general population just knows that if my child is asleep for X number of hours, they must be a good sleeper. But we really have to look at what that sleep looks like, which should be essentially silent and still with our mouth closed. So even if we're not hearing an actual snore sound, if you are hearing heavy breathing or anything like that, the mouth doesn't have to be gaping open. That is considered the start of what we call sleep disordered breathing. Another one that is easy to identify that I get in my office a lot is grinding. And
Mm.
because the sound of grinding teeth drives everybody crazy, and parents can sometimes hear that down the hall from their kids' bedroom. Um, and so, again, this grinding is a sign of our body being stimulated and trying to keep us from not falling into an apneic state or stop breathing while we're sleeping. And even when they go for their regular dental checkups, when their teeth look flat, or an easy one that you can see as a parent is these eye teeth or the canine teeth, they're supposed to be pointy. And when a child is grinding, they start to become really flat. So looking at these types of things are things that parents can, relatively easily identify on their own child and bring up to, a specialist in this area.
Is it common for both siblings to show these symptoms?
I see it very commonly. And I think because there's a genetic component to some of this, and then
Mhm.
there's an environmental component. So allergens, our diet plays a role in some of this as well, in terms of causing inflammation of the body and inflammation of the tonsils and adenoids. Um, Something that we treat and screen for in my office is tongue and lip tie, which there's also a genetic component there. And honestly, it's not just siblings. If you start to look at the parent, you'll see a very similar pattern. And sometimes that is the key to recognizing, is when a parent starts dealing with their own sleep apnea. And treatment for adults is really intensive. Whereas if we could pick up these chapped lips, moving children while they're sleeping, grinding early, the intervention is much less invasive and much simpler. And now we know these really early signs, obviously, the bedwetting, which is what we're focusing on today. Um, and unfortunately, not all of our pediatricians, but many of our pediatricians are not trained in looking at these early signs. And so I always encourage parents, if you think something is off, don't ignore that feeling. Go
Mm.
find whoever can explain what's going on, because these things a child doesn't magically grow out of. If anything, they get worse and worse, because the more the child is growing, if the airway is not growing and supporting that body growth, we're going to see more and more of these symptoms pop up. And unfortunately, bedwetting really starts to have a psychological component on
Ah,
children as well.
100%.
So, the fact that they feel embarrassed, they can't go for sleepovers, And as you mentioned about the chewing, it's not for lack of trying. I mean, all of these kids, they're not like choosing to bedwet. They just don't
Mhm.
have the control and the proper function of their body to help them out. And so, it's a really, when you really think about it, it's like we have to help these children.
Yeah.
And there is a way to help them.
Exactly. I tell my patients all the time, they feel so bad. So I tell them, listen, it's not because you drink too much water. It is not because you could not wake up to go to the bathroom. It's because you can't breathe. This
Yeah.
is a survival mechanism. What is the one thing that you have to do in order to survive? You should take your next breath. You can stay long enough without water, long enough without food, but you cannot
Absolutely.
stay very long without breathing. So your body goes through extreme ways sometimes to make sure that you can take your next breath. And
Yep.
sometimes it needs to release everything that is not important. That's an easy
Yes.
way to explain it. It releases everything that is not important so you can take the next breath. A lot of times these kids are moving around a lot. Why? Because as their airway closes, if you move, all of a sudden you have these awakenings, the child doesn't remember, even an adult, they don't remember, but you have this fragmentation of sleep where it kicks you back to stage one sleep, to light
Yes.
sleep. So you can move around and you can take another breath. You can open up your airway,
Yeah, and
move
that's
your tongue.
another thing is positioning can help open your airway. So, arching your head back while you're sleeping is a way that a lot of people subconsciously open their airway while they're sleeping. So, again, looking at the positioning of your child while they're sleeping is really important. And we see these symptoms improve with over time when we do treatment. It doesn't happen instantaneously, but as we open up the airway, as we train children to nasally breathe, these symptoms start to get better over time.
I don't know if you guys are like me. I love taking photos of my kids asleep. They are so
So
cute.
sweet. Yes.
And whenever you start learning about these things and you go back and you start looking at the positioning, I request from all of my patients a 20-second video of the patient sleeping about 90 minutes after they've fallen asleep. And 90 minutes, it gives you enough room to go through a whole sleep
Whole
cycle.
sleep cycle. Yep.
So I'm looking for tongue position, head position, body position. And, as a parent, sometimes it's really funny, these positions that these kids are sleeping in, and it shouldn't be like that. There's usually something going on.
Also,
Very
if you look at newborn photos, a lot of those newborns have their mouth open already and their heads
Mhm.
up.
Mhm.
So, when we talk about early intervention, we're not just talking about kids that are 3, 4, 5 years old. We're talking about kids that are a week old, 2 weeks old, because already they are having that open mouth posture. And we have to ask ourselves why, because that is not naturally what the body should be doing. And yeah, similarly, you look at all these cute newborn photos and the babies look adorable, but half of their mouths are open.
Mhm. I have a patient that just came to me last week, and my heart is broken for this little boy. And he's so motivated. He's so excited. He's like, "Are you serious, mom? Like, you found somebody that can actually help me?" They've tried it all and they've been ignored. Even recently went to an orthodontist, and this child obviously has a small maxilla. And they said, let's just watchful waiting, let's
Hmm.
wait one more year until you grow a little bit more. Well, if you're already underdeveloped, waiting is not going to push you ahead of the curve.
Yes.
Waiting is not going
Yeah.
to do anything. So if you're underdeveloped today, you're going to be underdeveloped a year from now.
Yes.
This is
And the
so
body is
important.
going to still try to grow. And so that airway is going to just support it less and less.
Exactly. But it is the craziest photo that I have ever seen of a head position during sleep.
Wow.
It is the craziest one. And I am asking them very sweetly and nicely to let me share because it is the craziest one I have ever seen. If you're listening to this right now and you have a photo of your child sleeping with their head all the way back, please, and you don't mind me sharing on social media because it's going to help so many other patients. Like Dr. Gandhi is saying, these patients, these little kids, they need us. They need us to find them out there. We need to be able to educate the parents. These are the things for you to look for, and there's something that we can do to help this child. Somebody recently asked, what is the role, and you mentioned a little bit, what is the role of ankyloglossia or tongue ties
Hmm.
in mouth breathing?
Yeah. So, ankyloglossia or tongue tie is when we have a frenulum under the tongue that is too tight or positioned in the wrong place, and it is limiting the range of motion of the tongue, particularly the positioning of the tongue to help with nasal breathing, to help with proper growth and development, is elevated in the roof of the mouth. That is at rest. That's where it should be basically anytime we're not using our tongue for a function. You can even try it now, whoever is listening. If you drop your tongue to the floor of your mouth and try to take a nice deep breath through your nose, it's a lot harder than if you elevate and suck your tongue up to the roof of your mouth and then take a nice deep breath through your nose. It's a lot easier. So if we are tongue tied and the tongue physically cannot make that elevated movement and stay elevated, we are now already prone to more resistance in our nasal passages to nasally breathe. The other problem that happens when our tongue sits low is that the tongue is not putting pressure on the maxillary bones or the palatal bones, which are two bones, the palatal bones that can be separated in order to grow. Those bones also make up the floor of our nose. So if our upper jaw does not grow correctly and spread out, well, then our nose does the same exact thing. It stays really small. And then we have these tiny little tubes that we're trying to nasally breathe out of, and there's a lot more resistance. And then things like our turbinates and our adenoids seemingly take up more space because they're in a tighter area. So the really crazy part is that our maxilla, 70% or so of growth is done by age 4. So if we have our tongue sitting low when we're little and we're just watching and waiting that tongue tie because it's not causing major issues, then we're missing this huge growth potential for our upper jaw and our upper airway. So this is, in my opinion, one of the biggest benefits of treating tongue ties during infancy, because we get that tongue elevated, we get that mouth closed, and we get that jaw and nose growing correctly. Can it be treated later? Absolutely. But then we're already treating the other things that have been impacted.
Mhm.
So some kids in my practice, they are showing signs of sleep apnea and lots of airway disorders really young. And if they're narrow already, I mean, we are expanding as soon as they have first molars. So 12 to 18 months, we're putting an expander in.
Oh my
Um,
gosh, what a
and
dream.
these kids in 3 months, they are totally different. And yes, we may still have to address a tongue tie and all of that. But, some of these kids have had releases. And, in our parenting, we are also doing things that are not sometimes helping that process along. So, even if I treat an infant's tongue tie, just doing that is not enough to retrain the tongue and make good habits. So things like avoiding pacifier use, because that's going to hold the tongue down and train it to do the wrong thing. Um, Doing techniques like baby-led weaning when we are introducing solid food is key to proper growth and development of the jaw and muscle function. So we want to skip soft puree foods. We want to, skip the little pouchy things. We want to make sure that we're promoting nasal breathing by, you can do saline rinses during infancy and
Yeah.
all, so there's a lot more that has to go in, but identifying the underlying dysfunction early is the best thing we can do. And um, doing that during infancy, in my opinion, is the best and the
Ashley,
easiest.
true. Ashley is asking, where do we take our kids to get checked for this?
Yeah. So unfortunately, this is still not a universally educated um, specialty in dentistry, in medicine, even in pediatric dentistry. But what I would do is, first of all, you can just Google like airway dentists in your area, and look on their website. Anyone talking about mouth breathing, tongue ties, early airway orthodontics, because it's not universally educated, there are also varying degrees of what practitioners are doing. So not all of them are treating tongue ties and doing early expansion and myofunctional therapy. So you may have to put some pieces together, but if you can identify one person, they usually have a network of people that they can
Mhm.
refer you to. Other great resources are, Airway Circle has a directory. The Breathe Institute in California has a directory. Um, uh, the Chrysalis, what I'm blanking on the name, but it's Autumn Hennings. She's a speech
Yeah.
language pathologist. She also has a directory. So a simple Google search will probably be a good
Yeah.
start. And honestly, even if you find somebody that is not fully into this, anyone that's even interested wants to help kids. So they will usually tell you, I'm not the person, but I have a person. And so it may take a little bit of time to find your network. But again, everyone's super passionate about helping children thrive in this arena. And so generally you will get hooked up with someone that can help you out. So, I'm sure Renata and myself were happy to also start that search with you so you can, message us and we know people kind of all over the country that are doing this.
100%. So just let us know. I always
One
tell
thing I will, sorry, not to interrupt, but one thing I will say is if you go to a practitioner that is not specialized in this and ask them to screen for it, you're likely going to get the answer that everything is fine. So
yeah.
don't make that mistake of just trying to go to any pediatric dentist or any, because you're going to get misinformation. I'm sorry,
Mhm.
Renata, I didn't mean to
No,
interrupt
it's
you.
fine. One of the best things to do is also contact a myofunctional therapist around you because they
Mhm.
usually already know which dentist to go to, which dentist
Yes.
to avoid, or orthodontist. We have our own little local network. What I do when I'm seeing my patients, I always open up the Airway Circle directory and I go ahead and I search who's around them to be able to do the proper referrals. On the first appointment, I do all my referrals already. Um, but if you start with a myofunctional therapist, first, they have area knowledge. And two,
Yeah.
they're
Mhm.
kind of already going to know. So if you're going to just any ENT or any dentist that's around you, like Dr. Gandhi was saying, you might not get a person who's actually trained on this. Um, for infants, of course, if you're having any issues breastfeeding, always look for an IBCLC, which is an international board certified lactation consultant. I always recommend two appointments for a baby, an IBCLC and a pediatric dentist who is trained in releasing ties in babies because they are also able to evaluate the tie. Actually, they are the ones that can diagnose if this patient has the baby has a tongue tie or a lip tie.
Yeah, and the therapy, like the myofunctional therapy and IBCLC is a great place to start because we always need to incorporate that in our treatment model. Um, and it's those appointments are very informative as well. So they give you a great like base knowledge of what's going on, and also can get your child, especially if it's myofunctional, used to being more aware before going to a dentist or before any other intervention. So I think I agree that's a great place to start.
Perfect. Do you recommend? Oh, hold on. Do you? I'm going to leave that one for later. Do you
Okay.
recommend occupational therapy assessment for bedwetting?
Yes, I think occupational therapy is helpful. More so, not just for the bedwetting, but even like any body treatment, OT, PT, chiro. We have to incorporate those therapies because the mouth and the airway is not isolated. It's affecting everything from head to toe. And that is from a breathing airway perspective, from a tongue tie perspective. And so those other therapies can certainly help. And in fact, in my practice, we require that you do body therapy in conjunction with oral therapy, um, because there's such a connection. But doing that in itself is not going to address the root cause as to why the bedwetting is happening, why we have more body tension, why we're missing gross motor milestones in babies, why we're gassy, why we're colicky, why we're tense, why we have torticollis. All of that is related to breathing and airway dysfunction. So I have many patients that have done OT for years and years and years. And it's not that it hasn't helped at all, but we still have the major problems going on. And that's because we have not addressed what the root cause is, which
Mhm.
is airway dysfunction and oral dysfunction and breathing dysfunction.
Yes, and these things are very complex. So if you go and
Yes,
get a release, you're not going to get all of the results. If you go
exactly.
and just do myofunctional therapy, you're not going to get all the results. You're going to get some benefit from every single one, but you have to do all
The
of them
full.
together. You
Mhm.
have to, of course, not every patient is going to need everything, but it's very important for us to be able to pinpoint exactly what that patient needs. And in most cases, you're going to have to see different professionals. We are very
Mhm.
complex individuals. That is another reason why not everybody's going to present exactly these
The same.
same symptoms. Even siblings sometimes will have different symptoms. One likes to wake up early, the other one, you cannot wake that child up for the life of you. And they both, may have
Have,
airway issues. So,
yeah.
very, very
And that's
important.
because the body will try to compensate. And
Mhm.
it's just going to do whatever it needs to try to make it function best. And every person does that differently. Every body does that differently. And so, the common mistake is that, oh, they don't have all the symptoms, or they
Mhm.
don't have symptoms in every single category. That doesn't mean that there's not an issue. It just means that the body has been smart enough to do a workaround in that function. But those workarounds catch up in adulthood.
Mhm.
We see it with adults all the time. So it may be working in the moment for your child, but the longer they do it, the more trouble it's going to be in the future.
Perfect. Ahead of time, we always get questions on Instagram. So, you guys, um, keep an eye out for our stories right before we go live with the Beauty of Breathing podcast. I post a question box at Maya Moves Instagram. So, you're not following us yet, please go over there. Share this with your mom friends and anybody who you think that may benefit from some of this information. So I have some questions over here from Instagram that came in earlier. So a mom said, I have a 1-year-old and they were recommended general anesthesia for tongue tie and lip tie release as she won't be compliant in a chair. Is general anesthesia okay for this age?
So, in my opinion, it really depends on the child. Um, Sometimes we don't use as deep as general anesthesia. We do like a 15-minute sedation if needed on that age. But honestly, most of the kids that are under 2 years old, I do them awake. Um, and it depends on what tool they're using. I use a carbon dioxide laser. It's called a light scalpel laser. It's extremely gentle and precise. It doesn't even require me giving the child a shot to do the procedure. We just use some topical numbing gel. So as long as the parent's okay, we put them in a big kid swaddle or burrito or whatever you want to call it, give them a nice big hug.
Mhm.
Um, and then the release takes me under a minute. So
Right.
in my opinion, I don't know that it's necessary to go through the risk of anesthesia for such a quick procedure. Um, and I think a lot of it does depend on the tool the practitioner is using, because if you're using something like a scissor or a scalpel, that is very hard to control in a moving child. Something like the CO2 laser that I use, the child does not need to be perfectly still. Also, it depends on the skill level. I'm a pediatric dentist. I never work on a still patient ever. So my tolerance for movement is much higher than, let's say, an ENT or who does most of their work under general anesthesia. They're used to a very still patient. An adult dentist or a general dentist, that a lot of general dentists do infant frenectomies and kid frenectomies, and that's great. Also, their population is generally more cooperative than if you're a pediatric dentist doing work on children all the time. So some of it is a tool, some of it is a practitioner. The short answer is no, I don't think it's necessary.
Perfect. Want to know if you think that having trouble with sleep also can happen if you have trauma. I love this topic.
Yes. Yes, absolutely. There's definitely a psychological component. to sleep. But I will say those that don't sleep well, sleep is a traumatic process in itself. So even besides the outside trauma, that's probably
Mhm.
the poor sleep is compounding that trauma because
Yeah.
the act of sleeping in itself is traumatizing to your body because it's trying to literally survive the entire time. Also, when we get to our deeper level of sleep cycle is when our body really starts to let go and process a lot of that trauma. Um, and if we're having poor sleep and constantly being in the level 1 and 1 sleep cycle, then we are not allowing our body to process those deep traumas, and so we hang on to them a lot longer. So absolutely go hand in hand with each other, and poor sleep is going to lead to more anxiety.
Oh
So
my goodness.
those those experiences that are traumatizing are compounded by the anxiety that you already have. So, even if you're trying to process them awake,
Mhm.
it's going to be much more difficult. So I mean, sleep is just the key to everything,
Everything.
everything. I
Everything.
always
Always.
say, I always say, like so many medical specialties would be eliminated if we
Yeah.
could just get our sleep right.
Yes. I always say that sleep is more important than nutrition and exercise. And every
It is.
single time you go to a physician, they're telling you about nutrition and exercise, but nobody asks about your sleep.
Sleep.
And if you don't sleep well, you're more likely to eat like crap and you're more
Mhm.
likely to not want to go work out because you're exhausted. So if
Yeah,
you
and
sleep
your body's gonna hang on to things that it doesn't detox correctly.
exactly. There's so much.
Yeah.
Somebody has a question about these habit correctors. There's so many of them out there. We don't have to name anybody, but are habit correctors a good option for young kids?
We're talking like for thumb sucking and those types of
Yeah,
things.
like my brace, I'll say one.
Okay, like those. Okay. Um, so I've had experience as a practitioner with several of these.
Hmm.
And I think they can work well in terms of retraining tongue positioning and promoting nasal breathing. In my opinion, I don't think they do an adequate job of expansion. If we need true bony movement of the maxilla and the mandible, I don't think you get it from something like those types of appliances. Um, and I've seen it firsthand with my patients.
Hmm.
All of them that I tried to do those with, I ended up putting in other appliances. I In theory, I think they would work well on a really young population that is super pliable, like under 4, under 3.
Yeah.
The problem is you need such good compliance, and that population is not going to give us that compliance. It also takes a long time. Even in that population, if you're going to get significant movement, um, 18, 24 months. For me, if I make a custom made expander on those little ones, you're looking at 4 months, maybe 6.
Exactly.
And then we're getting better sleep in 4 to 6 months, not 18 to 24 months. So
100%.
I basically don't use those. What I do use are things like munchies,
Hmm.
which are great tools in conjunction with therapy to help with nasal breathing, to help with strengthening the tongue for chewing, mouth closure, especially on the little ones because they are very difficult to teach exercises to. So, this is a natural way to have them exercise. The other thing it works really well for is teething if you stick it in the freezer. And the other thing that I love using it for is pacifier replacement. You can actually, the baby ones have a little passy clip hole on them. So we
Oh,
tell them just swap it out, just swap it out and have them go to town on that.
I actually
Um,
love that idea because they can still hold the passy.
yes,
It's
yes,
still
yes.
there.
And some of that is a comfort thing.
Yes.
I will also touch on, I know this was more myo brace related or myo, that
Mhm.
sort of thing,
Yeah.
but I will also touch on things like the need for a pacifier or thumb sucking habit because um, Traditionally in pediatric dentistry, we are taught to make an appliance that has little spiky things on it so that they can't suck their thumb. But what we're missing there is the reason kids need those things is because something else is dysregulated in their body. Their nervous system is dysregulated, which is very much driven by breathing and sleep, but it's also driven by alignment and cranial nerve function, which has to do with what we call fascial tension. And fascial tension can be caused by a tongue tie and poor sleep. And so by just sticking something in there where they physically can't do that, we're almost torturing a child, in my opinion, because
Yes.
we're
Thank you for
taking
saying that.
away the way that they soothe themselves without giving them any sort of tool to replace it
Mhm.
with or fixing the reason why. And that's why kids start to go berserk when you just stick an appliance in there. So our recommendation at the practice is doing craniosacral work or chiropractic care to help regulate the nervous system and our body's ability to soothe themselves by regulating the vagus nerve, which does a lot of that. Doing things at home like grounding with your child. You just go outside barefoot. You can do ear massage. You can do head presses. All these things really help your child regulate their nervous system, and then you work with them about getting rid of this habit. You don't just take it away and put something in there and say you can't do it, because it comes back to these children are not choosing to be defiant. They are trying to regulate their bodies.
I love that. Somebody's asking, what is the easiest way to assess a 6-year-old for airway dysfunction? I think we touched a lot on the symptoms already. What does it
Yeah,
look like when they come to your office?
sure. So even if children are presenting to our office for just a routine dental checkup, we are using a screening tool called the Ferris 6, which is 6 different components that put a child in a risk for developing sleep apnea. And many of them we've touched on, but mouth breathing is a big one. So mouth breathing versus nasal breathing. Dental wear, which would be a sign of grinding, so flattening of the teeth. What their tonsils look like. So enlarged tonsils. What something called mentalis strain. So yeah, if a kid is kind of like puckering their chin to try to close their mouth, that means they're straining a lot. And that is usually kind of a positional discrepancy. And then the other one is a narrow palate. So a way a parent can tell that on a 6-year-old is, are there spaces between the teeth? If there are no spaces between your child's teeth, that's considered underdeveloped. So we don't need teeth overlapping or crooked. We just need to see if there are spaces or not. So no spaces, intervention is needed. Spaces, you're in better shape. So
Perfect.
just have your kid smile.
I know all of us parents are so proud. Oh my goodness, my child has perfect teeth. They're touching and it's a perfect smile, and it's not.
I always say in 2 years, like if they're 6 in 2 years, that's going to look like a disaster because they're going to
True.
get their permanent teeth and it's going to be, so
I always say,
yes,
like a picket fence, a tooth and
yeah,
a space, a tooth and a
yeah,
space.
that's great. But it's funny because when I do early intervention and I make all the spaces, so many parents are like, they look crazy. I'm like, you will thank me in a few years.
Exactly. Should we be lip taping children?
Carefully and with guidance.
Mhm.
I don't recommend that parents just buy lip tape and start lip taping their child because we don't know what's going. I lost an AirPod. Hang on.
You're fine. Yeah. So lip taping, and I never recommend taping the lips shut. Don't ever tape the lips shut. We usually start during the day
Thank you.
until they
Yes.
get used to it. And then I have a very specific way that I teach parents how to lip tape. Not many people do it like me, but it's a more therapeutic way. It's with kinesiology taping, which is a tape used, by physical therapists to really work on actually muscle. So it's not a physical way that you are just closing the lips
Mhm.
because they have to. You're actually contracting the muscle. So that's what we're doing whenever
Is
we lip tape.
is that similar to the myo tape that goes around, or a similar
Similar.
concept? Yeah.
Hmm.
Okay. Yeah, that is the one that I recommend. But I always tell them, similar to what you say, is
Hmm.
start during the day. But also, we do a 3-minute breathing test in the office with just a tongue depressor. Um, and if they can't handle that, then they're not a good candidate for attempting anything like that.
And I like
But
to compare this as, growing up, my mom was always like, shoulders back, Renata. She would tap on my shoulder all the time. Shoulders back, Renata, shoulders back. Because I always had this awful posture, which I still do. I'm still working on it. That's why I've been going through expansion, tongue tie release. Now I have to do some body work to address everything else to make sure I can have better posture. But she always, would tap me and say, Renata, shoulders back. Of course, I don't want to look like I have bad posture. I want to have good posture and sit up straight like that. I can also breathe better. But and I got a brace when I was about 10 years old, and the brace is just, it's mechanical. It's physically pushing you in the right position. So that's the same thing that just taping somebody's lips shut is doing. It's a mechanical and physical way of you just closing it shut, but it's not addressing the habit. It's not addressing
mm,
why this patient can't keep their lips closed. It's so, yes, not lip taping unless you've been evaluated by a pediatric dentist, a myofunctional therapist, sometimes an ENT, to make sure that it's the right thing for that patient. Is there a correlation between consistent talking or yelling in sleep? Always about 1.5 to 2 hours after the 8-year-old falls asleep. This morning, he not only had the mouth wide open, but the head also tilted back. Send me a photo.
yes, there is. That usually happens in like the second stage of sleep, is when that talking and yelling. But it is a sign of sleep disturbance as well.
Yes, gotta get it checked out. Love the podcast. Thank you very much. What is the path of correction for class 2 division 2? What is that, first of all? What is a class 2 division 2?
Yeah. So class 2 division 2 is class 2 refers to how the molars, first molars line up. Top molar in, when you're biting down on your bottom first molar. Yes, thank you. A model would be fantastic. Usually the layman's terms that people say is that's an overbite. It's actually when you have your top jaw much farther in front of your bottom jaw, like Renata is
Oh
showing.
my gosh, I'm crooked.
Really, that in the dental term is called an overjet, how far your top jaw is in front of your bottom jaw. When it's division 2, the front teeth are actually tipped in and tilted back. Do your teeth move on that thing?
No, I
Okay,
wish.
I was like, that would be impressive. Um, and so, the teeth are almost inclined backwards, if you will, not sticking out like this. Um, so in this case, we were traditionally taught that we need to bring the maxilla back to meet the mandible to make that discrepancy less. Actually, what this is a underdevelopment of the lower jaw. Many times, which is surprising that when I tell patients this, the upper jaw is still also too far back. So we want to move everything still forward, even though there's such a pronounced discrepancy already. So the last thing we want to do is take that maxilla and pull it back, because then we are making the airway even smaller. We need to use sometimes appliances, but a lot of myofunctional therapy and breathing and tongue tie release to bring that mandible forward. The way the mandible grows forward is by proper swallow pattern and lip closure. So that is what we need to work on. So this is why we can't do orthodontics without therapy and looking at muscles, because it's not just about moving things. With appliances, the way we really move things is with function and muscle movement. So in my opinion, the treatment for class 2 division 2 is not bringing things back or extracting upper teeth and closing spaces. It is bringing the mandible forward. So figuring out why that mandible is receded. Um, The division two part, you can put on aligners to align the teeth. I'm not that
Mhm.
concerned about the tooth alignment. To me, that's just the jaw discrepancy is what I'm most concerned about.
Perfect. Thank you. I know that was a little bit off topic, but very, very important for everybody listening in. Um, Next question. Does removing enlarged tonsils actually help with bedwetting?
It can. Again, this goes back to not one thing is going to fix everything. Um, it depends on how large they are. Okay. Also, if we remove and why they're enlarged and how large they
Mhm.
are. If they are enlarged because we're chronic mouth breather and all we do is remove tonsils and continue to mouth breathe, they will actually come back. And we are not addressing the fact that we're still not oxygenating our body correctly because we're continuing to mouth breathe. Um, if they are so large that they are encroaching and we physically just, even if we expand and everything and start to close our mouth, we still are struggling because there's so much resistance. Same with adenoids. Sometimes we do have to take them out.
Mhm.
But if they're borderline, I try other things first. Um, Daily nasal hygiene can help calm things down. Looking at the diet to remove as much inflammatory nutrition that we're putting in our bodies, dairy, gluten, those types of things. If there is an underdeveloped jaw, can we expand first? So we are going to try those things first, generally, unless they're 3+ tonsils, like kissing,
Mhm.
so enlarged that we just can't get around them. And then we're going to reevaluate because we also know that those tissues are naturally going to shrink as the child gets older. So can we get there? Can we get them there and have them naturally shrink some? Or are we so enlarged that it is actually going to get in the way of our therapies and procedures?
Perfect. ENT says no tongue tie, tiny tonsils, and no deviated septum. Although my daughter says she cannot keep her tongue to the roof of her mouth, it resists or rests below. Orthodontic says no expander needed.
So I would go to a myofunctional therapist because what they're going to assess is that tongue not elevated because it's not strong enough? Does it just need some training? Um, is it because there's a tongue tie? Is it, and also I will caution and say the orthodontists, when they are looking at need for expansion, their lens is can teeth fit in? Can they fit in? And then can we just straighten them? um, they are not looking at an airway. So going to an orthodontist that focuses on airway or a pediatric dentist that focuses on airway, we're going to have a much different lens of what we're looking at. I actually don't really care about straight teeth. And I'm not saying I want to make kids look crazy. I'm just saying that is not my primary goal. My primary goal is a large enough jaw to support proper nasal breathing and an airway.
Mhm.
So I'm going to be looking at something totally different. Our measurements are different, our screening is different. So again, this is where, unfortunately, if we land up with the wrong practitioner, we're going to think that we can check the box and now this is not an issue when
Exactly.
really we just haven't had the proper screening. Similarly, there are 4 types of tongue ties. Some are super obvious to see, some are not. So, depending on what that ENT's assessment was, there may be a tongue tie there that is just not
Mhm.
easy to see. You're only going to pick it up on looking at movement and function. So, my recommendation at this point would be to go to a myofunctional therapist.
Perfect. Is zero point 0.5 grams children's melatonin a bad
Mm.
idea if the breathing is challenged?
I think melatonin can help, but I think it's a band aid. So I'm not a proponent of long term anything being
Mhm.
used. I think we need to ask ourselves why. A child should not need an aid to sleep. If it's a one off here and there, not a problem. But if it's something that we're having to utilize, that's not a long term solution.
Very, very good. We have so many good questions, y'all, but we have reached our time. How do I do the tongue depressor test?
Oh, you just take a tongue depressor or popsicle stick that, we've eaten the popsicle off of, and you just have the child hold it between their lips for 3 minutes. And what
Very
you're
good.
looking for is, even if they can keep it in, is there a lot of fidgeting? Like, are they panicking? Because then at least then we know they can do it, but there's still some resistance. Or are they taking it out and they can't do it? Then maybe we need to look for some more obstructions, or there's more of an issue. It's very simple. But put on a timer for 3 minutes, because 3 minutes is a long time.
Perfect. And some of the signs that they fail the test is if you see mental strain,
Yes.
not only if they can hold it, but do you see mental strain? Do they get fidgety? All of a sudden they start moving around. They just, do they look uncomfortable?
Mhm.
They might
Do
be
their
able to
eyes
hold
do their eyes get really big? You know?
I've had somebody hyperventilating 10 seconds
Yeah.
before. Crazy. Let's see. Please discuss cleft lip and palate and what to do if nasal cavity is occluded. An ENT does not, I guess, to address until rhinoplasty in the teenage years. There's a typo. Does not want to. Too late as a facial changes. Can you expand a child with the cleft palate?
You can. Those are very complex cases. Honestly, I
Mhm.
don't do it myself.
They need a
Um,
craniofacial team.
they need a craniofacial team, just because everything is so closely connected. Those are not straightforward expansion cases. Um, I wish I had more to comment
Offer.
on or share
Mhm.
with that, but it is honestly just not my area of expertise.
Perfect. Would myofunctional therapy prevent the need for an expander from an orthodontist?
It really depends on the situation.
Mhm.
Um, it depends how underdeveloped we are. The general rule I will say is no. I don't
Yeah,
think
very
that
good.
that in itself is going to be sufficient.
I agree.
Um, the only time, and this wouldn't be myofunctional therapy because myofunctional therapy starts a little bit older, but the only time sometimes I will see a 2-year old that is slightly narrow and they have a
Mhm.
tongue tie and they're mouth breathing. And I will say, let's address the tongue tie, let's address the mouth breathing. And because we're under 4, we may be able to self correct. That's the only
Mhm.
instance. Other than that, anytime I see a narrow arch and a tongue tie, we are addressing the narrow arch first with expansion, then we're addressing the myo and the tongue tie.
All right. Last question, y'all.
Okay.
Is a severe tongue tie in a 5-year-old, could a severe tongue tie in a 5-year-old be a cause of behavioral issues?
100%.
Mm.
The reason I say that is several things. Is we now have talked quite a bit about how the tongue plays a role in breathing and sleep. Poor sleep in children presents as behavioral issues: ADHD, hyperactivity, defiance. Um, Again, these kids they're not functioning well, they're not resting well, they're not getting to recharge. And so the tongue tie at this point in that age has probably led to some underdevelopment of other structures that are compounding this issue. But the root cause could have been just that tongue tie from birth. The other thing that happens that I see with kids with tongue ties is they are sensory kids. They
Mhm.
are, if you think about it, if you have a normal moving tongue, it is stimulating so much of your mouth and your nerves, especially that vagus nerve. When you are tied, nothing has ever really touched those areas as much. And so they are hypersensitive to those areas, and it makes them very uncomfortable, and it almost feels violating. It
Mhm.
becomes sort of a private part area of your body because it is not being stimulated.
Mhm.
These kids also tend to have a more processed diet because they can't handle the chewing and swallowing of more whole foods. So now we are compounding our poor sleep with not the best nutrition, which again, I have, these parents are really going through it. They're just trying to survive and get their kids to eat things. So there's no judgment there. But
Mhm.
these things all compound each other. So, um, I would say if you're having those behavior issues and there is a tongue tie that you know about or that you suspect, find a practitioner. I'm happy to help. I see children from all over the country, all over the world. I do virtual consults, but if I can help you find someone locally, happy to do that as well.
Okay, so how do I make an appointment with you? Do I go through your website,
Yeah,
email?
so either westupediatricdentistry.com or tanglewoodpediatricdentistry.com, and we are located in Houston, Texas. You can give us a call, 832-767-2227. You can find us on Instagram. We check our messages daily. You can contact us through there. And, happy to help your kiddos in any way that we can.
I will also make sure that all of this information about Dr. Pia Gandhi is in our show notes. We have some extra questions, which I'm going to go in our Instagram stories right now, and I'll answer them. One of them is the difference between MARPI and MSC. Since it's off topic, I will talk to you guys over there. We do have an ENT over here. Thank you, Dr. Colleen. She
Amazing.
said there's no contraindication to nasal surgery in younger kids if needed. So maybe a second opinion. Got to find the right ENT. Got to make sure it's a pediatric ENT. What do you think about tooth pillow? We just literally talked about tooth pillow, myobrace, and healthy start. They are all the same thing.
Mm-hmm. Yeah,
they're habit correctors. They're not expanders. They're great for really young kids if they can breathe through their nose, if they are done with myofunctional therapy. You cannot shove this thing inside a child's mouth if they can't breathe. It is not going to work. And I'm going to say this because I've been seeing way too many children be prescribed these habit correctors that is not the right prescription. So please go to somebody who doesn't do only these appliances. Go to somebody who has a more general or even more thorough, comprehensive knowledge of airway and does different things. Go to a myofunctional therapist and they are going to guide you. Go to somebody who's not attached to some of these companies.
Yes.
Okay, because sometimes if they are that provider, guess what? You're never going to walk into a dental office of somebody who only does alpha appliances and they're going to recommend a MRP. It's not going to happen. Yeah. So make sure that you go to somebody who offers different appliances and they're going to be able to find the right one for your child. What is the expansion device used for lower jaw? Dr. Gandhi was saying that we got to make sure the tongue is not tied. We're going to make sure swallowing is correct. That's going to help lower jaw come forward. Anything else?
Yeah, traditionally there are things like Herbst appliances and things like that. If you catch it early, you don't have to use those types of things. It's really about muscle function. You always have to be careful when you're using an appliance that attaches the upper and lower jaw together because you will have some retraction of that upper jaw. So
I see so many kids do the Herbst appliance and they end up with a much worse gummy smile.
Exactly. So really the key is early identification and muscle function and myofunctional therapy and nasal breathing.
100%. Well, thank you so much.
Thanks so much for having me.
Yes, hanging out with me on a Friday at noon. I hope everybody enjoyed. If you like this information, guys, please help us out. Share this. There is a mom out there praying for some information to help their child, and you guys can be the bridge to that. So please share this. This is going to come out on Beauty of Breathing podcast next Tuesday. So go over there, follow our show. We're on Spotify, Apple Podcasts, all of the podcast platforms that you can think of, whatever is of your choice. Please share this with your community so we can get airway to more kids. Thank you, everybody. Have a wonderful day.
Thanks, guys. Have a great one, Renata.
Thank you for joining us on another insightful episode of the Beauty of Breathing podcast. Make sure to join the conversation on our Instagram page, Myo Moves, and continue exploring the fascinating world of airway health with us. Until next time, let's breathe deeper, live fuller, and discover the beauty in each breath. Quick disclaimer: the Beauty of Breathing podcast has been produced for entertainment, educational, and informational purposes only. All of the content, views, and opinions shared by our hosts and guests
should not be a substitute for medical advice. Please consult with your healthcare professional for any medical questions.